The cornerstone of managing hypertriglyceridemia is targeting hepatic very low density lipoprotein, that is VLDL synthesis, and upregulating lipoprotein lipase clearance of triglyceride rich lipoproteins. For patients with persistently elevated triglycerides without severe genetic lipid disorders, lifestyle interventions often yield a more profound relative reduction than isolated statin therapy. Here is the evidence-based approach to lowering triglycerides without pharmacology. Carbohydrate restriction, the most potent dietary driver of hypertriglyceridemia, is an excess of refined carbohydrates and fructose. Fructose is particularly lipogenic because it bypasses hepatic phosphofructokinase regulation, driving unchecked de novo lipogenesis. Reducing simple carbohydrates decreases hepatic substrate availability for fatty acid synthesis, subsequently lowering VLDL particle secretion. Eliminate sugar-sweetened beverages, limit fructose, and transition to complex high-fiber carbohydrates. Soluble fiber blunts postprandial glucose spikes, reducing the insulin-driven esterification of free fatty acids into triglycerides. Alcohol cessation. Alcohol is a powerful secretagogue for VLDL. Ethanol metabolism generates excess NADH, altering the hepatocellular redox state. This shifts the hepatic balance towards fatty acid synthesis and away from beta oxidation. It also directly impairs the clearance of chylomicrons. For patients with triglycerides more than 500 mg per deciliter, strict abstinence is required to mitigate the risk of acute pancreatitis. For those in the 150 to 499 mg per deciliter range, limiting intake to rare moderate occasions or complete cessation is highly recommended. Weight loss and insulin sensitization. Adipose tissue insulin resistance leads to an unrestrained flux of free fatty acids into the portal circulation. Weight loss improves systemic insulin sensitivity, which suppresses hormone-sensitive lipase in adipose tissue, reducing free fatty acid flux to the liver, and upregulates lipoprotein lipase activity in the capillary beds, enhancing the clearance of VLDL and chylomicrons. A sustained caloric deficit aiming for 5 to 10% reduction in total body weight can significantly reduce circulating triglyceride levels. Aerobic exercise. Physical activity directly impacts lipid partitioning and utilization. Skeletal muscle contraction acutely increases local lipoprotein lipase expression, accelerating the hydrolysis of triglycerides from circulating lipoproteins to fuel the active muscle tissue. At least 150 minutes of moderate intensity aerobic exercise per week. The triglyceride lowering effect of an acute bout of exercise lasts for roughly 24 to 48 hours, highlighting the physiological need for consistency. Dietary fat modification. While total fat reduction is often mistakenly prioritized by patients, the type of fat is much more critical. Omega-3 fatty acids, eicosapentaenoic acid and docosahexaenoic acid are poor substrates for diacylglycerol or acyltransferase, the enzyme responsible for the final step of triglyceride synthesis. They also downregulate sterol regulatory element binding protein 1C, further reducing lipogenesis. Replace saturated and trans fats with unsaturated fats. Increase consumption of marine omega-3s, that is salmon, mackerel, sardines, 2 to 3 times per week. While dietary optimization is foundational, it is the combination of carbohydrate restriction, weight loss, and exercise that produce the synergistic upregulation of lipoprotein lipase needed for profound triglyceride reduction